Okay, the first hour is a quick, down and dirty, quick overview of hospice. We covered a lot of different issues that come up in hospice a lot. Now we're going to cover the chapter and go through the PowerPoint, and I'm going to try to go fast, and I always say that, and I never do, but I'm going to try this time to cut down on the stories and make sure that you get the information from the chapter that you need, and then we'll take another break, and then the last hour, if we're able to finish the PowerPoint, the last hour we'll work on the case studies, which are, I hope you find interesting and helpful, and then the math calculations, which most people enjoy doing that. Is there anything that you want to learn from the class? Is there anything in particular? I brought that up, but anything that you want to cover or talk about? Okay, alrighty. I think it's really important when you do a chapter to review your unit outcomes. So the things that we're going to talk about in the class in summary is hospice versus palliative care, legal and ethical issues, advanced directives, and of course religious and cultural aspects are very, very important. And then the signs of approaching death. A lot of you sound like you're very familiar with that, but it's something that we can do a lot to teach families about. A lot of the things we can't do a lot about it, just to monitor them and provide comfort measures, but it helps the family to understand what's going on. Quality of life, can't say that enough. That's so important in hospice. We don't have quantity of life, but we want to promote the most quality of life possible. And then we talked about we're going to work on the case studies and the medication calculations. In your book, it talks about types of loss. And, you know, when you think loss, the big loss everybody thinks of is death. But there's a lot of different kind of losses. We all have losses as we go through different stages in our life, different developmental stages, different parts of our life. We go through losses. And your book breaks them down into different things. The actual versus perceived loss. Actual is it is a real loss that even other people can see. One example would be somebody that goes through chemotherapy and they lose their hair. That's an actual loss. A perceived loss is internal. It's what you feel yourself. When something changes, your belief system changes, how you feel about things, and you perceive that as a loss, the way you view yourself. And it lists all different kinds of things. Environmental loss. Some of these are, it's like, stress can be good stress, bad stress. Some losses are actually good. It talks about moving to a new house, but that's a loss. You're losing your old house and you're moving on to something new. One thing on here is a typo. It says loss of aspects of loss. That's supposed to say loss of aspects of self. And that talks about when part of your personality has changed. Part of what makes you who you are is different and has changed, and that's a loss, and you feel different because of that. For instance, if an athlete has a limb amputated, they lose that part of their self, and their whole life may change because of that. So that's if you were in a choir and you liked to sing, and you had cancer of the throat and you had a laryngectomy and you couldn't sing anymore, that would change, your life and your aspect of yourself. Okay. The next thing, and if I'm going too fast, you can give me the thumbs down. I get excited and I get going, and sometimes I talk too fast. In grief theory, in nursing, we're professionals. We want to base our work on a theorist, and that's, been a foundation of nursing, professional nursing for years. I do have to tell you that, you can go to the next one if you want to. In hospice, I've never actually had heard of these grief theorists until I started teaching this course. You don't hear these names a lot, but it's important to review these chapters. It's in the fundamentals book. There's a really good table on page 267. You can review it, and I'm not going to do that today. If you will review that, they're all a little bit different. These theorists all wrote their theories at different times in the course of history, but there's similarities. In grief theory, it starts out with finding out about the loss, acknowledging, recognizing the loss, and then the phase of working through that loss, and then when you are able to come to grips with it or work through and have peace with it. So they have different ways of doing that, but I'm going to let y'all read that on your own. Okay? And Kubler-Ross is huge in hospice, and we'll talk more about that later. That is a theorist that we talk about her a lot and use her work quite a bit. When somebody's going through grief, there's a lot of different things that affect grief. And in the book, it talks about the significance of the loss. If it's I have so many patients, they'll tell me, I've been married to my wife for 63 years. I hear stuff like that all the time. I had a caregiver the other day. I went to see him, and some of these caregivers, these little husbands or little wives, when they're elderly and they're taking care of their spouse, their devotion, it's just inspired. Well, I touched it. It's heartwarming. I walk away from there feeling, oh my goodness, I'm so honored and blessed to have been part of this. These caregivers, their whole life is taking care of their loved one. And when one spouse has dementia and the other one doesn't, I saw two people this week that the husband cares for the wife, and the wife, especially when they're in the wandering stage and they don't know what they're doing, and they go to the kitchen and take everything out of the drawers, and you got to make sure they don't turn on the eyes on the stove or they don't get outside. And these caregivers are so devoted, and they spend their whole life taking care of their loved one. And I had a caregiver the other day, and I always try to acknowledge, you're doing such a great job taking care of your wife. It's so important for them to hear that and get that encouragement, because that is an exhausting job. And the man looks at me, he goes, you don't give up on your partner. We've been married 62 years. And then I had another gentleman last week tell me, I said, until death do us part. And I just got chills, and I'm just like, oh, it's beautiful to see that. But so that loss is going to be a lot different than if your next door neighbor passes away, or it's just different, and that grief will be much, much different. Support systems are very important. If a person has a lot of support, then their grief work is different. They're supported by people they love. In Florida, a lot of people move down here for the weather, and their families are all over the country. So we get people in our care center all the time that have nobody there but us, because their family's in Michigan and California and wherever they are, and they're trying to get there, or they're estranged, or whatever the situation is. And of course, we have a lot of people that have huge families that are very loving and supportive, and it's very beautiful. But there's a lot of people that we are their only family at that moment, so we try really hard to give them special attention. Conflict at the time of death. There's just all these different things that add up in each situation, and you have to figure out what's going on with that person and address it. We talk a lot about spiritual and cultural beliefs, and we'll talk about that more, and that will keep coming up. And I think the bottom line on this is there's charts in your book about cultural beliefs and spiritual beliefs that are excellent. They spell it out really clearly to review those. I think the bottom line is, if it's someone that you don't know their belief, or even if you think you do, ask them, what's going to work for you in this situation? What's going to make you more comfortable? What do you want us to do? What do you not want us to do? Very important, and just do what they say. For one thing, they're so happy that you're interested in them and you genuinely care and you want to do things the way they want to do it. But they like to teach you and tell you, about their culture and their religion. Okay, on developmental stages, and any comments at any point, please feel free to interject anything. When you're going through loss and grief and end-of-life care, the person that's experiencing this, a lot of it depends on their age and their developmental stage and how they view this. Children think that everything happens around them is affected by them. Things happen around them because of them. You've probably heard if there's a divorce in the family, it's really important to tell the children, it's not your fault that mom and dad got divorced. We love you. It's not anything you did. It's us. And we know that as adults, but little kids, they don't have a clue. They think things happen because they were a bad boy or something they did. So it's really important during when someone's dying. I always encourage families to include the children, because the unknown is a lot more scary. If they can come and kiss Grandpa goodbye one more time, or come and tell Grandma and hold her hand and tell her that they love her, and see that she just looks like she's sleeping and she's okay, that it's much better than the unknown. It's scarier not to see it. And then it's up to the family to decide what they feel like is the best thing to do. This thing about children believing that things happen because they're responsible for it somehow is called magical thinking. So you can just explain to them what's going on. Grandpa's heart is worn out, and he's getting ready to go to heaven, or whatever your belief is. And he's lived a good life, and we love him, and we're gonna kiss him goodbye, and we'll see him again in heaven, or whatever your belief system is. But to explain to them that it's not because of them. Teenagers, they're trying to figure out who they are. They're trying to figure out how they fit into the world, what their role is. And the thing about teenagers is sometimes if there's a death or a loss, they feel like they have to be strong for their adult in their life. And the problem with that is they don't get to work through the grief on their own. So it's really important to acknowledge that let them grieve, and it's okay to cry with them, things like that. As an adult, we expect, we're going to have loss in our life. Our parents are going to die. Even I try to pass away, pops up sometimes. Our parents are going to die. People we love are going to die. Our friends. So it's part of our life, but it's something that we have to learn to deal with. And then older adults, they have compound losses, especially if their children die before them. That's a very difficult thing to deal with. In types of grief, when you were talking about your mom being, so upset and everything, it made me think right away there's some kind of complicated grief issue there. In uncomplicated grief, people go through, they mourn, they're sad, they cry, they have physical symptoms, they can't eat, they can't sleep, depending on the level of grief they're going through. And how much time do you get off from work for a bereavement? 3 days. That's pretty much universal, I think. So at the end of 3 days, you come back to work. Are you okay? Have you worked through the grief? You've barely scratched the surface. Grief can take weeks. It can take months. And you need to tell people that they get upset. My loved one died 6 months ago, and I'm still crying, and I'm still upset, and I can't eat or I can't sleep. That's normal. It can take weeks and months for uncomplicated grief. People that are in complicated grief, they get stuck. Something happened at the time of the death or during the dying process that they're stuck on that and they can't move forward and find resolution. I have a cousin that's my age that I'm very, very close to, and her son died when he was 22. And it was very sudden. The circumstances were it was just a lot of ambiguous stuff. There was no questions were answered. Nobody could really tell her what happened. And she's better than she was, but this has been years ago. She was really stuck in trying to find out answers, and it was heartbreaking. So there's a lot of reasons that happens, and the best thing you can do is just, of course, refer them to a bereavement counselor, but just to listen and support and help them, mainly just listen, help them try to work through it. Anticipatory grief is something we hear in hospice a lot, because when someone is dying and their dying process takes months or weeks, and then when they get to where they're actively dying and they're no longer eating or drinking anything, and they may be in a coma for days, the family has a lot of time to do this anticipatory grief where they know the death is coming and they're already grieving. But it doesn't have to actually be a death. It can be any loss that is coming up. If a person is faced with, they have colon cancer and they're scheduled for surgery and they're going to have a colostomy, they can grieve the loss of that function of their body and the change, okay? And there's a lot you can do during that time to support people. Main thing is listen. And answer the questions as much as you can, and if you don't know, try to find out and try to get them resources that will help them. In the physical stages of dying, I'm going to refer you to this blue book. And I was going to pass these out. I only have one per row. This is it's a flip chart, and this one's in Spanish. It's a little bit different way. The flip chart is basically the same information, and it's a little bit a different way of looking at it. There's a lot of these tools, and in your book, let's see, in the fundamentals book on 271, it's basically the same thing than the Gone From My Sight, the blue book. It's also in your book. It's listed. And I only brought a few of those. If anybody wants one, we can copy them off. You can keep them, or if you don't want them, you can give them back. But the same information is on page 271. And this book has been in hospice for literally decades. And I think it's really great because it has in print what we're saying. We're teaching the families what to expect when the person has months to live, or when they have months to weeks, or weeks to days, or days to hours. We always try to give people a range like that. We try not to say numbers. A lot of people in hospice are comfortable saying numbers. My medical director does it all the time. He'll tell a family, I think it's going to be 3 or 4 days, or I think it's going to be about 2 weeks. And I respect him. He's a tremendous physician. But I personally, as a hospice provider, I don't feel comfortable saying numbers, because I feel like people get hung up on that number, and when those 2 or 3 days have passed and their loved one's still alive, they're looking at you like, what happened?
Interest is kind of...
Yeah. So I never say a number. I had a lady on the phone. I had the message to call a significant other of a patient that was in the care center, and I told the lady, she goes, and we get asked this question constantly, how much longer? How much longer? And I would say, I don't know. and my educated, my experience from what I'm seeing because of this, their feet are blue, they're not swallowing, they're having apnea. I think it could be any time to a few hours. However, sometimes people will last for a few days, and then we talk more about why. But I think it's really important to just give them that range. I had this significant other, I called her, and she's asking me how much longer, and I said, well, because if he's doing this and he's doing this, I think he's probably got a few weeks to live. She goes, a few weeks? Do you mean 3 to 6 weeks? I promise. I said, no, ma'am. I don't know that it's 3 to 6 weeks. I think it's a few weeks. And as we're seeing changes, we'll let you know. So I think it's important to do that. But when someone has months to live, 1 month to 3 months, the person begins to withdraw. They want to sleep more. And families sometimes get really upset about this. They want to spend more time with their loved one, and they want them to talk to them and interact. But people, they start to get ready to say goodbye, and they withdraw, and they sleep more and eat less. They're in bed more. They may have more symptoms. So you treat them with comfort measures that we'll talk more about that later. They usually prefer liquids at that time, and that's what we talked about. Caregivers have a really hard time not feeding their loved one, and that's something that you have to provide education. Then in 1 to 2 weeks before the person dies, they start to have a lot more physical changes. They get pale. Their vital signs change. They get much weaker. At this point, they're probably in bed most of the time or all the time, or they're bedbound, and they require total care with their activities of daily living. When a person is hours to days before the death, sometimes they'll have a surge of energy. We call it a rally, or there's different terms for it. All of a sudden they're awake, they're animated, they're talking. And I always tell the families, this is a gift. If there's anything you want to say it. If you want to say, I love you, I'm sorry, forgive me, I forgive you, this is a really good time to say it. And that gives family members a lot more peace after the death, that they got to say, there's no unfinished business. They got to say everything they needed to say. When there's only days to hours before the death, the person is definitely bedbound. They're semi-comatose. They may arouse or they may not. A real important thing to tell families is if they're at this stage and they're not responding to you, hearing is the last sense to go. I always say this to families. Let's just assume that they're hearing everything we're saying. We don't know exactly what they're hearing. They may hear every word. They may hear bits and pieces. But we're just going to assume, or we're just going to pretend they're hearing everything we're saying. At that point, sometimes families will want to go out in the hallway and talk. But a lot of families, which I prefer, to stay in the room so that their loved one, the patient, can hear us. And just keep talking to them. And I think it's important for you to tell families it's okay to hold their hand. It's okay to stroke their hair. You can get in bed with them. You can hug them. You can hold them. Because people sometimes they feel a little hesitant, especially in a care center when there's a hospital bed, about getting in bed with somebody that they've slept with for 60 years, But we encourage them to do things like that. At the end of life, and it talks here about what you were talking about, the dehydration and stimulating endorphin release. People have Cheyne-Stokes respirations, which of course is when they have a period of apnea, maybe 10 seconds, maybe 30 seconds. That can be the longest minute you've ever spent in your life waiting to see if another breath is coming. Then they take a real deep breath, they breathe fast for a while, and then gradually it slows down and they have another period of apnea. I think it's real important to tell families that once they start having these Cheyne-Stokes respirations or apnea, they may go back to their regular respiratory pattern, or they may not. You just never know. And people don't go through these phases, all these different signs. They don't do it in a linear progression. They don't just do it and they're done and they go to the next phase. They go back and forth. In the days to hours before death, a lot of times their circulation changes. The circulation slows down. There's more of the oxygenated blood is going to the vital organs, so the hands and the feet turn blue and purple, and sometimes the knees get mottled. And then it talks about the dysphagia when the people can't swallow anymore, and sometimes at the end of life, people get restless, and if they can't talk to us anymore, they can't tell us what's going on, we look for nonverbal signs. If they're restless, we treat them with low doses of morphine and titrate it up as we need to. We use Ativan a lot. If they're really agitated and we can't get them under control, we might try Haldol. Sometimes we use Thorazine. We use different medicines, but we do it in a stepwise progression, and it's in a very organized, systematic way. We do use sub-Q medications when they can't swallow anymore, or if they're getting congested, we're trying not to put more fluid in their mouth, and we use sub-Q medications. Okay. So I think it's important when you're teaching families, if you do have literature, is to explain, what you're handing them. Don't just hand them information. Talk about it, and they can put the two things together. Any questions on that? And we've touched on the signs and symptoms of approaching death. We might go into that a little bit more later. The next thing we're going to talk about is the Palliative Performance Scale. And I do have some copies of that. And they're not very good copies, and I was just going to kind of pass each row and let you pass them down. And I'm sorry that's not a very good copy, but that's the best one I could come up with. But that's a little bit more detailed, but it's also on the slide. We use this a lot in hospice. This is a tool that when we get report, we'll use this and we'll say this patient is a PPS. We call it Palliative Performance Scales, PPS. They're a PPS of 50, or they're a PPS of 10. You and I, we're all a PPS of 100. We're all functioning, healthy, living our life. Zero's death, so it's a continuum. Most people come on hospice. They can come on at any point. A lot of people, if they come on hospice and they're on hospice for a few months, then they're usually a 50 or a 40. 50 is when they're still ambulatory. They're starting to spend more time in a bed or a chair, but they're still able to get up and walk on their own, and they're independent, and they might need a little help in their activities of daily living, but pretty much they can accomplish most of those on their own. This is when people are still going out, and going out to church or out to eat, going out with their families. This is a really important time now to get your legal affairs in order, to get all your paperwork together, to figure out what you want. You don't always have the luxury of having this time, but if you do, it's important to encourage them to do things like this. PPS of 40, that's when people are mainly in a bed or a chair. They do get up and walk around, but more and more they're spending more time in bed or in a recliner. They're weaker. They may need more help with their activities of daily living. They can probably feed themselves. They're probably oriented, but they just need, they're starting to need more help. 30% is they're bedbound, and they can't get out of bed. They can't ambulate anymore. So then you have to work with the caregivers on how to take care of someone who's in bed all the time. They have a very poor appetite. They don't want to eat. They may just want liquids. This is when we're talking about they may have weeks to months to live, probably more like weeks. Then when someone's a PPS of 20, then they're bedbound, and we call it preactively dying as a term that's used. They're only tolerating sips of fluid. That's when you might use a syringe to put a few drops of fluid in their mouth, or they might be able to swallow a few bites of pudding or soup, or take sips. And people go up and down in this scale too. They can be a 21 day and a 30 the next day. Or I've even seen people be a 10 and the next day they're a 20, the next day they're a 30. You just have to assess them sometimes I was going to say day by day, but sometimes it's hour by hour to see where they are. And where they are on this scale affects the kind of care, not the kind of care they get, but what you're focusing your care on and how you're delivering it. You give medicines differently. If they're a PPS of 10, if they're actively dying and they can't swallow their pills anymore, then you have to discontinue their routine meds and use a different method of giving them their medicines besides them swallowing it. Use sub-Q, we use rectal meds, we use topical meds, we put gel, rub gel into wrists or into the skin, and then sublingual, a lot of sublingual meds. Okay, any question on that? When the nurses call me from the field, part of my job is the nurses on 3 different teams call me from the field when they're in a home, and they'll call me and they'll say, Linda, this patient is doing this. And if it's a patient that's on Dr. Wadsworth and my service, then I can give the orders. If it's a patient that they have a different primary physician, then they're using me as a resource. And we talk about a plan of care. And they'll say, I'm going to call Dr. So-and-so, and I'm going to suggest this. Or they might say, what should I tell them? What's my recommendation? So I always try to engage them and use that as a teaching moment to say, have you thought about this? But usually, they have an idea what they want to do, and I'm just kind of tweaking the idea or saying, yeah, that's a great idea, call them and ask for that, or have you thought about this? And a lot of times they want me to review their calculations or do their calculations on medicines. one of the first questions when they call me, I'll say, what's the PPS? What's the diagnosis? If I don't know the patient, what's the diagnosis? What's the PPS? What's the goals of care? And sometimes it's pretty straightforward, and I don't have to go into all that. But frequently, like, can I give them an enema? Yes, give them an enema. But if you're like, if it's a question it's about pain medicine or an antibiotic, I'll ask them all those questions to see where the patient is and where the family is and where we're going with this, because that will, where their PPS is, where they are in the dying process, will influence what medicine we give, what route we give, and our plan of care. Okay? Any questions about that? Okay. We're doing good. Okay. The next thing is Kubler-Ross's stages of death and dying. And I actually was able to see her speak, Elizabeth Kubler-Ross, many, many years ago. I got the opportunity to see her speak. And she was a pioneer in the world of end-of-life care and hospice care. And we definitely talk about her stages of death and dying and use her as a framework for our practice. One of the main things that you hear people talk about with hospice patients and families is denial. It's a very, very strong coping mechanism. And it's okay. It's okay to be in denial as long as you don't get stuck there. And people will go back and forth with this. They won't go through, they're in denial on Monday, and Tuesday they're in anger, Wednesday they're in bargaining. It's never that clean. It's really, really messy going through all of this. And you go back and forth, and you might in one day go back and forth, and that's okay. What might somebody that's in the denial stage, what might they say?
They're not dying.
Right.
They're just sick.
They're just sick. That's right. Not me. I think I need another CAT scan because I don't think that's right. You know, they want to research it more. They want to verify more. They just can't believe this is really happening to them or to their loved one. You know, he doesn't really have whatever. You know, he doesn't really have cancer. Or he doesn't really have dementia. He's just a little forgetful now. You know, whatever it is. So it's okay for them to be in denial. You just listen, but then you provide them with open-ended questions. Get them to think. Mainly listen, like I've said before. But you know, you can give them a lot of support. And then, are y'all familiar with these stages? Okay, I'm sure you've heard this before. So hopefully you get to acceptance. That's our goal, is for everyone to get to acceptance. A lot of people do. And I think that's a misconception of hospice. A lot of people that are in hospice are ready to die. They've had a good life. They're ready to go to heaven, especially if their spiritual life, I feel like, if they're comfortable with their spiritual beliefs. A lot of people do get to acceptance. Not everybody does, but quite a few people do. That's a good thing. Okay, end-of-life care. In end-of-life care, as we said, it's holistic. That is so important. We have a whole team of people in hospice that are devoted to each aspect of this end-of-life care. Physically, of course, the nurses and the doctors and the CNAs are going to work on the physical symptoms. And we all kind of overlap. We all listen. We all do each other's jobs to a certain extent. But primarily, the nurses and doctors and the CNAs are going to provide the physical care. On the emotional aspect, that is so important. Like my gentleman that got his pajamas on and got in bed and he was ready for the shot. You know, his was emotional. He did have physical symptoms, which we were able to control. But his major problems were emotional, and that's not unusual. You know, we have patients come in that they're estranged from their families, and just all kinds of situations, you name it. And some of them are really heartbreaking. So we do what we can, and like I said before, the social workers keep telling me after all these years you can't fix everything. So we do our best. Spiritual care, we have chaplains that are non-denominational. It's their full-time job. And in hospice, they're non-denominational. Many of them have other jobs or pastors somewhere else or whatever. But in hospice, they're not Baptist or Catholic or anything like that. They are a spiritual person that the patient and their family can talk to. I've even had patients that claim to be agnostic or atheist, but they wanted to talk to the chaplain just in case, you know, and tell the chaplain he can come by. I don't want him to read the Bible, and I don't want any praying, but let him come just in case. Okay, whatever works for you, I'll tell him. So it's interesting. Legal and ethical principles, we're going to get into that a little bit more, but that is so important of end-of-life care. I mean, I just think that's imperative that we are ethical with our patients. Legal, you know, that's kind of a nice thing about hospice. I guess it's possible to get sued in hospice, but it's not a big concern. I've never heard of it happening. You may have. I have never. But I know when I worked in ICU before and I get a report, and in the report they're like, this family's lawsuit happy. Be really careful. And you're like, oh, great. You don't hear things like that in hospice. And then respecting the patient's wishes. It's all about what the patient wants. And I think if you're dealing with a family and they're having a hard time and they're in the denial phase or whatever, or they're fighting among themselves, or they can't decide what to do, or they want you to stop giving the patient pain medicine so they don't get addicted, or one of those things, I always try to refocus, what would your loved one want? What would they want? If they could talk to me right now, and of course if they're alert and awake, I ask them, of course, but if they're at the point they're semi-comatose or comatose and they can't talk anymore, what would your loved one want? And try to refocus that. And a lot of times that's very effective. Okay, you have end-of-life care and you have palliative care. What's the difference? Is what?
When there's no cure, or that you can't fix it.
Right. Palliative care is more comfort care. And now this last line isn't exactly correct. I got to, when I was reading the book, that's kind of how I think about it. But in palliative care, it's comfort care. It's symptom management. The patient does not have to be terminally ill. They actually can be. There's no cure available. But you're looking at a long time. You're looking at months to years. With hospice care, a physician has to certify that, sign a certification that he feels like the patient has 6 months of life or less left. In palliative care, all hospice patients do receive palliative care, which is comfort care. You can have a palliative care service that is not for hospice patients. Does that make sense? Okay. Palliative care, we have our medical director has started a palliative care unit, or it's more like a team. It's not a specific place. But at Halifax Hospital in Port Orange near Daytona, he has started a palliative care service. And he sees a lot of patients that are not on hospice. They may never be on hospice, but he talks to the patient and their family, whether it's symptom management. A lot of times it's a trauma and the patient's put on a ventilator. He talks to them in the palliative care service. Sometimes those people go on to hospice care. Sometimes they don't. But he's started that, and that's going. He's just very, very busy with that. A lot of times people with palliative care also, as in end-of-life hospice care, they think that they won't be getting medical care anymore. But that's not true. They still get good medical care, just not curative care. Okay. Now with hospice care, the big thing with hospice care is that the patient is at the end stage of a terminal illness. It doesn't have to be cancer, and probably all of you know that. When I first started talking about hospice, I was a volunteer in the 80s, and then in the 90s I started working as an RN, and people didn't know what hospice was at that point. I would call people on the phone and say, we got a referral from your doctor, you've been referred to hospice. And they're like, hospic? What is hospic? And you had to explain what it was. But they're now, most people have had someone in their family that's been on hospice, or they've had some experience with it. But to be on hospice, a physician has to say you have 6 months or less left of life. Your prognosis is 6 months or less. We do get people that it's kind of that denial thing. They say, oh, when we got on hospice, it's not because our loved one is dying, it's because they're in pain and we're on hospice to get their pain controlled. Medicare is set up for people who are at the end stage of a terminal illness. Medicare gives us criteria sheets. They're like worksheets, and sometimes they're a little bit hard to figure out, but for the most part, they're very specific on what end-stage dementia is, what a person that's at the end stage, the last 6 months of their life or less, can do or not do, or end-stage COPD or end-stage heart disease. And then cancer is a little bit, that goes more in a stepwise progression. Usually it's easier to predict. The dementia, heart disease, lung disease, people can live for years and years with this. Parkinson's, any disease, ALS. So what does the last 6 months look like? So Medicare gives us these guidelines, and we go by that. Quality of life, as we've said before, is very important. And another thing with hospice is that dignity. That you give families, the patient and their family, the support, the education, the resources, the physical care, the emotional care, and the spiritual care, so that they face their end of life with dignity and they're surrounded by comfort in their home or wherever they may be. ALF, we have 2 homeless patients right now on one of my teams. We meet them behind one guy behind a gas station and one guy in a shelter, wherever they live. We meet them there. Okay? Any questions about any of that or input? Okay, very good. All right, legal and ethical issues. I put on your desk, I gave you a present, and it's a living will and it's a power of attorney. There's one in your book, in the Med-Surg book on Chapter 9, there's one on page 114. It's a little bit more detailed. I've seen these come in on patients' charts that are pages and pages of legal words. This is the simplest one I've ever seen. I had a local attorney gave me these. And if you fill this out and you make sure your family knows where it is, this is one of the best gifts you can give your family. I still, to this day, my parents will not fill one out. I've given them countless copies, and they just can't bring themselves to write it down and fill it out. But this is just a very, very important thing. When you make your wishes known and you fill out, you sign a DNR. Are y'all familiar with the DNR? The yellow copy is what we use in Florida. The patient signs it, the doctor signs it, and when a patient signs a DNR, if it's in the home, they're supposed to tape it up on the refrigerator or somewhere that if the neighbors come rushing in, or paramedics or EMTs come rushing in, they see it and they know what the patient wants. They do not want to be resuscitated, okay? With a DNR, sometimes it gets a little sticky when the person has told their family what they want and everybody's clear on it, and yet somebody comes in from out of town and they have unresolved issues and they're not breathing. We got to get them to the hospital. We got to get them on a ventilator, whatever. And their family's like, no, 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 they don't want that to happen. Or they're not eating. We got to get them a feeding tube so that we can feed them. No, no, no. Remember this, they don't want it. If a person signs this and it's a valid DNR, the doctor signed it, it's all in order, you follow the DNR, okay? Now, I've had paramedics and EMTs tell me otherwise. I've had ER nurses tell me that it's different in their facility. But I'm just letting you know that you're covered. You follow the patient's wishes. Do not resuscitate. In our care center, we've had family members come in, and at the last minute, they're just not ready for them to go. They got to talk to them about one more thing. They got to tell their husband one more thing. They got to tell their son one more thing, or whatever it is. We want them resuscitated. We do not do that. We don't have a crash cart. And if we know this is going on, we're proactive. We try to address it before we get to the point where the patient's not breathing anymore. And that's never really happened there. It could possibly, because sometimes people fool you and they die before you expect them to. But we just tell them we don't have a crash cart. We don't do CPR here. If you want that done, you call 911. What we do when to be on hospice, do you have to sign a DNR? No, you do not. A lot of people come on hospice that do not sign a DNR or do not have a DNR. That's okay. Typically, when they're on hospice, they get the chance to work through this, to ask the questions, to figure out what they want. People almost always or sign the DNR, or if they're unresponsive, the family at that point can sign the DNR, and that's okay. But if we have a patient in our care center, Fish Hospital is like 2 blocks away, and they're a PPS of 20. Which means bites and sips, they're in and out, but they're declining and their urine output's going down. They're only tolerating sips of fluid. Their feet are getting cyanotic. We're having a little gurgling. We're having a little apnea. And we're headed towards a PPS of 10, and the next step is death. If they're 20 and have not signed a DNR, either me or Dr. Wadsworth goes in and talks to them and says, look, it's time to decide. You don't have to sign a DNR. This is all about what you want. It's all about what your loved one wants. I'll say that first. It's all about what your loved one wants. It's all about what you want. But it's time to decide right now. Not this minute, but we need to go ahead and let you know we don't have a crash cart. We cannot code your loved one. They have not signed a DNR. If you want to be resuscitated, it's time to go back to the hospital. It's a lot better when the person can make that decision, and then we do whatever they want. And we're, very supportive. We get non-emergent transport. We make arrangements. The hospital knows they're coming. And I don't know how y'all do that, but if the person can no longer talk, we look to the family and we say, what would your loved one want? Do they want to be kept alive? Do they want to be resuscitated? And I try to prevent it and present it as unbiased as possible. So that they can make the decision they have peace with. Sometimes we have people that go back to the ER, go back to the hospital, go back to ICU, get back on a vent. But most often at that point, people sign the DNR. But it's their choice. It's up to them. Yes.
I had a patient who was on crisis care for about 3 days. I had the patient and the wife with the POA.
Okay.
And after about 5 minutes, she just couldn't bring herself to sign
Yep.
the data. And we talked and we educated and we talked and talked. The social worker came out and she just couldn't bring herself to do it. So I think like a day before he passed, and I went in one night and she said, if he's having any problems or whatever, I want you to do CPR. So I told her, I said, we don't do CPR. You have to call 911 and then they come out and that's But by the following morning, she did sign. But sometimes they're so adamant.
Right.
Sign.
Right. That's absolutely. I've had experiences similar to that. Yes.
Does the person, like if the patient is not responding anymore and they haven't signed the DNR, do they have to have the power of attorney to sign the DNR?
Usually they have somebody that can sign for them. If they don't, then we know that ahead of time. We know that there's no POA, there's nobody else to sign. You know, I can think of a situation where a lady was in a nursing home and her family was estranged or whatever, and the nursing home was her POA, and they didn't sign it. That was very complicated. But typically, you address it ahead of time. You know ahead of time there's no DNR, and we don't have anybody coming in to visit this person. They don't have anybody to sign for them. So you try to address it when they're still awake and alert and say, we'll do whatever you want, but these are your options. What do you choose to do?
Usually it's something done like first thing. You want that done and resolved so you know and it's not too late. And then you don't have much issues.
Really important to be proactive and not wait, until they can't talk anymore. Was there a hand up over here?
So, hospice nurse, if you're on a case and they code and they're not a DNR, you don't do CPR?
You have the family. If the family wants to call 911, they call 911.
And you, in that time frame, you just, most of them don't even have ACLS.
Yeah. Yeah, there's no need for it. We don't need it.
You're preparing them for
But like the family can't sue you because it's like in your policy that you don't do that?
Well, I mean, the family can call 911.
We have paperwork that they have to sign, and they sign saying we know
That they
that
understand
hospice
Right,
doesn't do
right.
that. Condition paperwork.
The key there is when you see that person declining, you address it right away. And the best time to address it is when that patient can talk and tell you what they want. But it's really important to address it early and take care of it. If for some reason they have an acute event and they die quicker than you expect, which that happens, we just tell the families they're crashing, they're not doing good, they're having agonal respirations, this is going on, they're declining, they're going to die. If you want CPR done, call 911. This is the time to call 911.
So you probably just start encouraging them when you see the modeling and when you
Right,
see other steps.
right.
Like, look, you want to go,
Right.
let's do this now.
Right.
As a nurse, would you call 911? Even if the family does not want to do it?
I've never had it. I've never had it come to that. I've never had it that. I've never been in that situation where that was the choice. There was always, it was handled ahead of time, and the family either said it's okay, we're going to let them go peacefully, or they go ahead and call.
I've had one experience with the family wanting to go out and be in an inpatient unit. Us as nurses took charge. We called 911.
Okay.
Stayed with the patient.
Yeah, the family
Okay.
asked me to. I think I've had it happen.
Okay.
One time, the family asked me, would you please call 911? And I called and said,
Okay.
I've had it twice now. All contact just says the family, you want to call 911 now, it's time to do so.
Okay. All righty. Hopefully it doesn't come to that point. Usually it doesn't. This is another thing when you're talking about living will. A living will is you're giving written directions on how you want your health care done at the end of life when you can no longer talk. And the form I gave you is very simple. There's a place at the bottom if you want to give special instructions or different instructions. This is another thing that's phenomenal. It's called 5 Wishes. Have you ever seen this? I'm going to leave these here, and there's one copy. But you can, on the back, there's places where you can order it. I'm going to leave these here with you, and I couldn't bring enough for everybody. My social worker wouldn't give me 25. But I went to a seminar one time on how to fill out 5 wishes. This goes into a lot of detail on exactly what you want with end-of-life care. It even talks about your funeral, what you want. You can put what you don't want. And when I went to this seminar on how to fill it out, they said start at the back because it's different sections. I think it's 5 sections. And the last section is the easiest one to fill out because I've opened it a couple times and it's like, oh, I don't know what I want to do about this yet. You know what I want to do. So, but the back part is just demographics, just filling it out. So start at the back, do the last section first if you choose, and then go towards the front. This is another thing. If you fill this out, put it with your living will. When you fill out who you want the POA is the person that you're picking to when you can if you can no longer speak to your POA is your voice. They're going to tell your healthcare provider they did not want IVs, they did not want a feeding tube, they did not want to be coded. Or if you do want any of that, they're going to be the one to say, yes, they want a feeding tube. Yes, they want to be on a ventilator. That's fine, whatever you want. But you need to make sure and tell your POA that you're putting them down as the person that's going to be talking for you. And you need to sit them down. And it's better if you sit down with your whole family and explain exactly what you want so there's no conflict, okay? Very important to get all of that witnessed, dated, put it in your safe deposit, your little, whatever you have, safe deposit box, your little fireproof vault. So a lot of people give their doctor a copy, give their attorney a copy. The most important thing you need to do is tell your family where it is. Because a lot of times people say, oh, I know, Mother filled one of those out years ago. I have no idea where it is. It doesn't do a bit of good. If we don't have it, it doesn't exist. So it's very, very important to tell your family what you want and where you're putting your documents. Yes?
Years ago, I filled out one. I don't know how you feel about this, but it made sense when they told us. It said, if you know your family would honor your wishes and there wouldn't be a conflict, then a family member would be appropriate. They said, for some people, they recommend a close friend. That way, if it ever comes down to that, there's not that animosity in the family. Like, we should have done this. He's different as you. I mean, I thought that was a good rationale. So I had a good friend of mine who's mine.
That's a good point. I've heard it said, don't put down somebody who can benefit from your death, like they're going to inherit your estate. But a lot of times, I've been advised on that, but a lot of times people do put their family members. So, it's just up to you, however you want to handle that. Okay? Alrighty. Ethics at the end of life. Any more questions? Or I think I gave out everything on that. Ethics at the end of life. When we've touched on this quite a bit, or we've talked about it, we've talked about truthfulness. You have to be honest. I find when people ask you a question, if you answer them in a kind way, and a lot of it is communication, effective communication, and you just take it a little bit step further. Make eye contact, listen. I always try to sit down with patients. When I see them in the care center, I pull up a chair to the bedside, I sit down at their level. So I'm eye to eye, I'm not standing over them. I ask them to mute the TV because a lot of them will have the TV blaring and they're hollering at me over the TV and I'm hollering back over Jerry Springer talking about something, And I don't think that's very therapeutic. So I ask them to mute the TV. I ask for their permission. I'm going to sit here with you. And they really seem to appreciate that. Have you heard of the studies done when a physician walks into the room and talks to the person and leaves, and then the physician comes in and sits down at the bedside for exactly the same amount of time? Always the perception is when you sit down and talk to somebody, they stay longer. That's evidence-based. So I think it's really important to try to do that. Patients need to be the one to direct their plan of care. And sometimes they're going to want somebody else to do it, but if you can get them to do it, it's a lot better. And if they come on hospice earlier, that works better too. Goals of care, what do you want? I talk to family members about this a lot. I ask the patient, of course, if they're awake. When they come in the care center and their symptoms are out of control, we're going to start you on this medicine. Usually, it's the disease process that makes people sleepy. However, sometimes the medicine makes you sleepy. After 2 or 3 days, your body gets used to the medicine. You don't have that side effect anymore, but you're more comfortable. However, as we're increasing the medicine or changing the doses or adding new medicines, if you get sleepy, is that okay with you? Would you rather be sleepy and comfortable or possibly more alert and maybe not as comfortable? Usually they say sleepy and comfortable. It's really important to have this conversation with people. Usually they say sleepy and comfortable, and that tells you which way to go. If you're figuring out calculations and you're going to round up or round down, it helps you to know what to do, where they're coming from, what they want. They might say, oh, my son's coming in from out of state. I'm going to see him tonight for the first time in 2 years. I want to be wide awake when he's there. Then after that, I'd like a little bit more medicine. So we just do what they want to do. With withdrawing or withholding life-sustaining treatments, a lot of times this takes a lot of support for families. If somebody's been started on tube feedings, tube feedings definitely have their place. They're wonderful in certain situations. But if somebody's dying, you cannot imagine how many times we get people with feeding tubes that are never used. The person never wanted it. They never want it used. They don't know why it's there. Get it out. And of course you don't, but you can't usually. But it's just really important to provide education. We can't let mama starve to death. This is another thing that we talk about every week in the care center and in the homes doing visits. And you have to explain this is not starving. Starving is when it's a healthy person that's hungry and they want to eat and you're withholding food and they starve. This is the disease process has made it to the point, and I try to say whatever it is, if it's cancer or heart disease. The heart disease has made it to the point where your mother cannot tolerate food anymore. She doesn't want it. She's not hungry. Makes her nauseated to try to eat. So we're not going to feed her anymore. Or the tube feeding, there's too much residual. When the nurse is checking how much feeding is left from the last feeding, it's still in her stomach. It's not going anywhere. Her body can't use it. If we put in more fluid, it can back up into her lungs and she can aspirate. It can cause a lot of complications. Sometimes you have to titrate down on these type of things. You turn the amount of feeding down until you get it turned off. You just have to go along with what the family wants and keep providing education. But if it's a feeding and there's too much residual, we don't feed them anymore. And then, of course, pain and symptom management are crucial. Let's do a couple more slides, and then we'll take a break, and then we'll come back and do the case studies. Euthanasia. Is euthanasia, you know the answer to this from what we've said already. Not. Is that possible? What?
Also not legal in this country.
Yeah. And now in Oregon, there are, physician-assisted suicide is legal, and that's the only state that I know of so far. But it's not legal in Florida. We cannot do euthanasia, and that is a huge misconception. People think that people come to the Hospice Care Center for euthanasia. That's not true at all. Organ donations, very, very important. That's something that you can do, whatever your setting is to provide people with the opportunity for organ donation. And that's just a huge need that people die every day on waiting lists, waiting for kidneys and various things. And that's a real important thing you can do as a nurse, is to be an advocate and give these people that are grieving the chance to have an opportunity for the death of their loved one to mean something and provide the gift of life to other people. Okay? Why don't we take a break? Oh, go ahead.
I just had a quick question.
Okay.
If somebody's basically actively dying, organs shut down, can those organs be donated?
No. In hospice, it's very rare. We've had people that donate eyes. We've had people that gave their whole body. We've had some people that had mad cow disease. And they were actually approached by a board of people that were doing research and asking if the family would donate the body. Now, the kicker to me there is the family has to pay to donate the body and transport it, which I think is horrible. So it's a cost to the family. But if they're willing and in a position where they can do that and provide the research, other people won't suffer from that, is where they get their comfort. But I don't know of hospice patients. Nobody in our care center would be a point where they could donate organs. That would be more like a ER or ICU nurse, could provide that to the family. Okay, why don't we take about a 10-minute break and we'll come back and finish this up. I just want to make sure I can write on the board later. Okay, how we doing? Everybody okay? Any questions, concerns? Okay. All right. Let's talk about therapeutic communication at the end of life. And it's basically, I would say, similar to any kind of therapeutic communication. I used to teach that class when I was an instructor here. I would say the things that we haven't talked about are maybe the nonverbal cues. I don't know if we've really talked about that. I guess we really have, talking about eye contact. I think some of the barriers on page 283, I wrote that down in your on chapter 15 in that book. Sometimes a barrier maybe for even healthcare providers, not necessarily hospice providers, but a lot of doctors don't like to talk about dying. A lot of nurses don't like to talk about dying. That's not unusual. And it seems like in some areas where treatment is more aggressive, perhaps ICU, perhaps ER, maybe not, that maybe the healthcare providers, they're just in the mindset of aggressive, invasive treatment. That's their job. That's what they do. So maybe it's hard for them to switch gears and give the families options. If you have that, if you're in that situation or a coworker is, you can always say, what about a hospice consult? You know, what about a DNR? What about palliative care if hospice isn't appropriate? So you can initiate that. If you're not comfortable doing that, you can talk to another coworker who is. But nonverbal cues is the eye contact, just taking time to listen. And then the barriers to, I think when we were talking about doctors and nurses that are uncomfortable talking about death and dying, you have to face your own mortality. A lot of people are not comfortable talking about other people dying because that makes them realize that their death is going to happen someday. Some people are not comfortable with that. I'm very comfortable talking about that. Right now in my life, I always have been at this point. I don't know what's going to happen in the future, but I've always been very comfortable talking about that. It's never been an issue with me. But there's a lot of things I can't do. You know, people will say, I can't believe, how do you work in hospice? How can you do that? That's just something that I can do, and I'm very comfortable with it. There's a lot of things I'm not good at and I can't do. I found my niche. I found, you know, what I can do. I think another barrier, people are afraid they won't know the answer. I think this job, working at the college, taught me how to say I don't know more than any other job I've ever had. And I had to learn to get comfortable with that because you can't know every question every student's going to answer, no matter how much you prepare and research and read and know your material. Somebody comes with a question, you're like, I don't know. So it's okay to say that, as long as you say, I'll look that up. And whatever you tell someone, you have to follow through. If you say, I'm going to look that up and get back to you, you have to get back to them. Or, you know, we'll look more into that later, whatever. But any other barriers y'all can think of that would prevent? Cultural differences sometimes do. That's something we have to work at sometimes. Religious differences, we have to accept people where they are. That's a huge thing in hospice, is accepting people where they are. You hear that over and over. You got to meet them where they are. Any comments? Facilitating grief work. I tend to do that a lot at the care center, or if I'm making a home visit. Usually when I'm making a home visit, people are not actively dying. I happened to have that happen yesterday, but typically on my home visits, it's called a face-to-face encounter now. Medicare requires that, and I have to go out and say, yes, the person should be recertified. They should stay on hospice another benefit period. But in the care center, we have a lot of people that are actively dying. So when I go in a room and if somebody's a PPS of 20, what's a PPS of 20? What would your patient look like? Right. They're starting to get into the dying process, but they're still possibly awake at intervals, possibly talking at intervals, taking sips. So when someone is a PPS of 30, 20, and they're still talking, and I go see a family member and I talk to the family or the patient, this is a good time to talk about, we talk about life review. If there's anything you want to tell your family member, that you love them, that you're sorry, you forgive them, you ask their forgiveness, if you want to talk about holidays or something special they did in your family. Grandma cooked us Thanksgiving dinner every year and it was so much fun. You know, or Daddy helped us carve the pumpkin every year and we went on a hayride and it was so much fun, whatever it is. For them to talk about it, it's very important. It brings joy to the person that's dying, and it gives a sense of resolution and closure to the family that they've got to say these things. So it's really important to encourage them to express feelings. Sometimes people don't understand. We may only have a week or so or a few days or a few hours left. We need to go ahead and do this grief work. A lot of times at the care center, people will bring in pictures, lots of framed pictures. Sometimes they'll tape the wall full of pictures of the person on a motorcycle or riding a horse or whatever they did. See a lot of wedding pictures from the 1930s and 40s that are so gorgeous. A lot of veterans, their family will bring their picture in uniform from World War II or whatever, Korean War, whatever it is. We do veterans pinnings at our care center. I don't know if your hospices do that. Probably do, to acknowledge the veterans. We do a pin, and a veteran that's a volunteer or a team member reads them. We have a little thing that we read them and we give them a certificate, and that is very emotional. We thank them for their service to our country. And sometimes we'll have family members of the dying person that are also veterans, and we'll pin everybody, and it means so much to them. People need to find meaning in their life, and sometimes at the end of life when they get, I didn't get to do this, or, my kids turned out rotten, or I had a lady tell me that a few weeks ago. My kids are rotten, and I don't even want to talk to them. But, hopefully, I had this one little lady that was like 90-something in a nursing home the other week, and she was getting her fingernails painted, and she told me that, I can't say a bad word, can I? That her husband was a bitch, and I said, a what? But then it was sad because she said that he hit her, which was very sad. But she was calling him all kinds of names, and she was so cute because she had her rouge on, and she had her nails done and her jewelry on, and she was talking about that he was an SOB, and it was so cute the way it was so funny. But people need to find meaning in their life. They need to die peacefully. They need to find out, oh yeah, I did raise 5 kids, and we did have some great times, and they're lousy now, but they were great at one time. Or we did have some happy years in our marriage, and we did have this business, and we were able to support our church or whatever it is. So you try to keep them going, and try to find meaning in their life. People that are at peace at the end of life, emotionally at peace and spiritually at peace, they die much easier and much more peaceful. It takes less medicine. They go easier. Sometimes people will just hang on and hang on and hang on, and it's just so right. That's absolutely true. They wait on somebody to arrive. They wait on an anniversary.
They wait on somebody to let them die.
Right. Right. They wait on someone to give them permission. It's okay. You can go. You don't have to worry about us. We'll take care of each other. You have to give them permission. It's time to go. But if they have all that has happened, they go much easier. And as I mentioned, I always tell families, keep talking. As long as they're breathing, you keep talking to them because they're hearing what you're saying.
My favorite question to ask, especially when you have a married couple, that first one's going, they've been married 40, 50, 60 years, I always say, tell me how you met. Stories are like amazing.
That's a great idea.
And they'll talk about that. I mean, you'll get a good hour out of that. They really just say how cute he was, and he had the blue eyes and this.
That's a great idea.
And that's like my go-to #1 question for a married couple.
That's excellent. Yeah, that's excellent. Very, very good. People in the care center, they bring their dogs in, bring pets in. Don't get so many cats, but we get lots and lots of dogs, grandkids. But it's okay to laugh. Sometimes people think death is somber and solemn, but families will start talking about their loved one and tell silly stories and funny stories, and you're all laughing together, and that's good. I've seen some deaths that were actually very beautiful when the person is dying. I happened to be filling in for a nurse when I was still doing home visits as an RN, and went into this house, and I said, this person's dying. And the family did not understand. She was having agonal breaths. She's, we're any time now. Call anybody you want to call. All the daughters came in. There was a daughter at each foot, holding each foot, a daughter holding each hand. And I was like, close enough that if they needed me, I was there, but I didn't want to be in their space. I wanted to give them this time because I knew she was really close. And they all started singing. And they were singing to her, and they sang her into heaven. It was really beautiful and joyful. She looked so peaceful, and it was really a beautiful thing to see. You may think that sounds like an oxymoron, but that's what I believe, and that's what I think, and a lot of hospice providers think that too. In caring for the dying person, and let's see, page 116 of the other book, the Med-Surg book, the Iggy book. And if you don't have your book, just write down. There's a little a chart. I wrote that down, 116. And this talks about some of the things when we were talking about the PPS scales, and we were talking about the blue book, the signs and symptoms at the end of life. I have this talk frequently at the care center. And then when you're talking to people about what the person is going through, what the stage they are, most of the things that we're seeing, and I'm sorry if I'm repeating part of what I've said before, when you're addressing physical needs and you're pointing out to the family, you're showing them, see, their feet are cyanotic, their hands are cyanotic, this is what this means, this is just something we're monitoring and keeping them comfortable, there's nothing we can do about this, we just want to let you know what we're seeing. when you're addressing physical needs of someone and you're going through all these symptoms that are possible, everybody doesn't have them, they don't do them and stop and they're done, they go back and forth. You need to keep in mind that if a person is physically uncomfortable, if they're in pain or they're constipated or they're having urinary retention or they're nauseated or they're itching or they're anxious or they're short of breath, any symptom, they cannot really, it's hard for them to talk about their spiritual needs if they're throwing their guts up. You know, you got to get them comfortable physically first, and then they can work on unresolved issues. So pain medicine, you know, aromatherapy, massage therapy, guided imagery, all this stuff does not take the place of pain medicine and anxiety medicine and pain management. So you got to get their pain under control. Let's see. Just trying to think. Okay, I think it's in the other book. Let me go back and forth here. No, that's okay. In one of these books, it talks about what's in a comfort kit for hospice, and those are the medicines that we use a lot at the end, especially at the very end of life. And we've mentioned those, Roxanol, which is liquid morphine. We use that for pain and shortness of breath. We start low, go slow. Then if they can't swallow, we can go to a sub-Q route. In the care centers, I don't know if y'all do that in the homes. If you have, if you have supportive care, if you have a nurse at the bedside, you can do that. We typically try to do things in the homes, interventions the families can do, that non-medical people can do, and try to teach them. Do a lot of sublingual meds, crush little tiny Ativan pills and put it in their cheek. It's absorbed well that way. If people get delirium, they get really agitated. A lot of times we'll use Haldol and Thorazine at that point to try to get them comfortable. If they have secretions, we use drying agents, anticholinergic, like Levsin or atropine drops or scopolamine patches. Sometimes Lasix will help with that if their kidneys are still functioning enough. So we try to get their physical needs met. Some of this is a little bit of a review. I know we've talked about at that point, if someone can't eat or drink anymore, to provide the family with the support and the knowledge, it's okay if they don't eat or drink. We offer it, but as they decline, they're not going to be able to drink. When people at the end of life if they have symptoms and they can't tell us, just like trial and error, we try different things to try to get them comfortable. As I said before, constipation and urinary retention, we're not really aggressive with bowel movements at the very, very end of life. If people are still eating, we are very aggressive on them having a bowel movement by every third day. That's part of report, is their disease process, their PPS, and their last bowel movement. Because if somebody's on pain medicine, they've got to be on a bowel protocol. And if you let your patient that's on a long-acting opioid get constipated, it's terrible. I mean, they can get impactions, it's painful, it's embarrassing, and it's completely needless. We get patients a lot of times from the hospital, and it's amazing the orders they have. They're on 5 different pain medicines. They're using long-acting pain medicine, PRN, no bowel protocol. They haven't had a bowel movement in 5 days, and they're nauseated.
And they call and give report, and you say, when their last BM, and they said, well, it's been like, actually they haven't had one since they were admitted, but we gave them a cold lace this morning before we got the discharge. Or you're like, you gave them what?
Yep.
Yeah, they had cold lace.
Yep. That's exactly right. So it's really important to put them on Sinicot S is what we use, because it's a stool softener and a laxative that gives you the mush and the push, and get rid of it. And so at the end of life, we are not, unless like somebody comes to us from the hospital with that situation and we don't know when the last bowel movement was, the nurse does a digital, they have stool, then we'll give them a suppository just so they're more comfortable. We don't get real aggressive with that at the end of life, but if they're restless and in delirium and agitated, that's something we address. As far as Foley's, we do use Foley's to prevent skin breakdown. We always have to talk about the benefit versus the burden. If you put a Foley in and somebody that has months to live, probably you're going to get a UTI at that, and you got to deal with that. At the very, very end of life, a lot of times we'll put a Foley in just so the person doesn't have to be turned so much, to protect their skin and to prevent urinary retention. What else can I tell you? At the very end of life, physical needs, it's like somebody that's been a diabetic all their life, and they've been, well, not all their life, but for years, they've been checking their blood sugars, they write them down in a log, they eat this, they do their insulin this way. Sometimes it's very hard for family members to stop the AccuChecks. If if the patient is not eating anymore and we're watching their blood sugars, we'd rather their blood sugars be a little high. In the 200 range, we'd prefer that over 40 or 50. That's a lot harder to treat. So we're a lot more lenient, and that people that have had it ingrained for years that you've got to follow this diabetic diet, or a cardiac patient, you've got to follow a low sodium diet and fluid restrictions, and you tell them it's okay. It's all about comfort. It's okay. They can eat cake 3 times a day. Or if they're a cardiac patient, they can eat salty pretzels and salty nuts, and it's okay. Let them drink whatever as much as they want. At the care center, it's not unusual for me to write an order that a patient can have alcoholic beverage of choice, one a day PRN. And if they have 2 or 3, I don't care. It's all about their comfort. If you've done home visits with people and they're telling you about what they smoke, you're just like, I don't want to know. I don't need to know. I don't need to know. As long as you're comfortable and you're happy, I really don't need to know. Had that happen before. Probably have too. So they can't do that in the care center, but they do smoke cigarettes when they're still up in their wheelchair. They'll go outside and smoke cigarettes.
2 beds with scotch.
Yeah, we have people that can have one more beer. They can't even swallow anymore. Well, you can dip the sponge on a stick in the beer and swab their mouth. If that makes him happy and that makes you happy, we're happy. Then once their physical symptoms are addressed, then you can look more at the psychosocial needs, trying to find resolution. Spiritual needs, a chaplain, of course, is a huge help with that, but anybody can listen. And then cultural needs. Okay, I think we've covered a lot of that. Let me look at my notes and see if there's anything else I want to tell you. I don't think so. Any questions? We use, a lot of the same medicines. I like one medicine that takes care of 3 symptoms, 2 or 3 symptoms. I prefer to use that, like Ativan. Ativan is good for, which is lorazepam. Of course, it's good for anxiety. That's the primary use. It also works great for shortness of breath. It works for nausea. Haldol is for agitation. Haldol works great for nausea. Intractable nausea and vomiting, sub-Q Haldol, person can be in a totally different place in 24 hours or less. ABH gel, we use that. It's Ativan, Benadryl, Haldol gel. Rub it in their wrist. It works great. They don't have to swallow it. But if they're nauseated and they're vomiting, you got to try to get around the oral route. So we use the gels. That works very effective. Postmortem care. In postmortem care, in any aspect of their care, it's a good idea to involve the family as much as possible. And most families want to be involved, but like I said before, sometimes you have to encourage them. And offer them that opportunity. If they don't want to, that's okay. But offer the family the opportunity to be involved in care. In postmortem care, what we do is we do after the death, we tell the person, yes. I've had people that the person has been dead for hours, and they wait till you get there, and they say, are they really dead? And they can't believe it until you say, yes, they're really dead. You give family time with the person that's died. The person that's died, you give them a bath and hygiene. If the family wants a special gown or dress or whatever, you put that on them. And then you give the family more time to say goodbye, and then you call the funeral home. You put the head of the bed up if they're in a hospital bed, or prop their head up. You can't prevent rigor mortis. The limbs are going to get stiff. So you put the patient, probably they're not going to be in the home long enough for that to happen. They're probably going to go to the funeral home before that happens. But I've had situations where the family wanted to wait for a number of hours for somebody to come from out of state or from far away. And so we try to do everything we can to work with the families. So you put the person in a comfortable anatomic position just so they look natural. You raise the head of the bed up because the red blood cells start to lyse, and the person can have a darker discoloration, so you don't want the face or the head to be darker, so you raise the head up. And then you respect any cultural or spiritual preferences. In some religions, there's different things that people do. I think it was talking about in the book, and the Jewish religion, and please correct me if I'm wrong, that people that are not Jewish don't touch the body any more than possible. I actually learned some more things when I was reading these chapters. Sometimes people want a special prayer said or a special song. Whatever makes them comfortable, whatever gives them peace. That's what we try to do. Okay. Oh, okay.
Oh, no, I was going to say, they used to tell us that even after the body's, there's no longer life in the body. I used to have an instructor that used to say that it was best if the mouth is open,
Oh.
and if there were still people that was going to come in and see the body, and you knew you had a certain amount of time before rigor mortis, just to put something to keep the mouth closed,
Okay.
so that when the body's stiff and you take off the thing, it doesn't look like the
Oh,
mouth
okay.
is open.
Okay. All right. Okay, that's interesting. At our care center, they have a little angel they're knitted, and they put the angel on their shoulder. They put a white rose on the door. And that's just our custom. Everybody has their own customs to try to honor that person and to acknowledge what's going on. Okay, it's very important in self-care to be aware as a healthcare provider at the end of life care in any area of healthcare. This applies to anything, but you need to try to take care of yourself. You need to be self-aware. How do you feel about death and dying? Are you comfortable with it? If you're not, that's fine. There's a lot of things that you're good at and you're comfortable with. You can't be good at everything. If you have a lot of losses very fast and they somehow they hit home with you. It's like you don't have favorites, but somehow you just connect more with other people. Or sometimes you're taking care of a patient that's just like, wow, this could be me. And it just kind of hits you harder. We take care of a lot of people in their 40s and 50s. People that are in their 40s a lot of times have children living at home, even in their 50s, have children, small children or teenagers living at home. There's a lot of grandparents raising their grandkids. There's a lot of more families that have children in their home. 40-year-olds and 50-year-olds, completely different than taking care of an 80-year-old that's dying. These people that are younger, they want to live for their kids. They want to do everything they can to stay around for their kids. So it's very different, and you have to address that. Some hospices will have memorial services. They'll have different ways of acknowledging. They might have a service for the families so many times a year to invite everybody in and have a service and say the name. We have one team that we have a meeting once a week. It's called IDG, Interdisciplinary Group, and they'll read off the names of the patients that have died that week, and the chaplain will put a rock in a vase for every person that's died. And then if anybody wants to say anything, then they have the chance to do that. It's kind of like group therapy, sort of. And be good to yourself. Pamper yourself. Exercise. Eat right, and develop your relationships with your friends and families. Don't work all the time. Spend time with your friends and family. Okay? Yes?
About funerals and memorial services, I read something and it may be out of context, so I want to make sure it's right. But it's basically saying that provided the family doesn't object, that it can be considered appropriate for caregivers who are there at the end of life to attend the funeral memorial services
Absolutely.
for their patients.
Absolutely. When I was a manager for a hospice, and one of the things that I encouraged was that one team member go to the funeral, because families really, really appreciate that, and it means a lot to them. As we've gotten bigger in hospice and we have more patients per nurse and higher caseloads, that's not always possible now, but that used to be pretty routine to do that. And a lot of times, like I was talking about, if it's a patient that really hits home with you, it can give you closure. But it means a lot to the families. It's absolutely appropriate. It's okay to cry in front of families. You don't have to, and you don't want to boo-hoo. You don't want the family member comforting you. You should be appropriate. Because I did have that happen with one of my nurses one time. But and last week, there was this man that he was in our care center. He was in his 60s, and he had cancer, and he had brain mets, and he came in for pain management. And when he came in, he was alert and oriented and ambulatory, and he's one of those people that walked in and never left. And that's really hard on families. He walked in, he was okay. What happened? His brain meds obviously took off because his personality changed. He had a delirium. He got combative. He got very confused. We could not get him comfortable. And his son was younger than me, but in my age range. And somehow it just hit home with me. I don't know. The whole family, they were so loving and so wonderful, and they loved him so much. And he didn't look like he had cancer. He wasn't thin. He just looked normal. But he went from one day he could swallow to the next day he couldn't swallow anything. And the day that I was seeing him and his delirium was so bad, his son was trying to drip water in his mouth. This is very recently this happened. And the patient looked at me, he goes, "Call the deputy, get me out of jail." And I said his name, "You're not in jail, we're going to take good care of you." And his son is like, "Dad, let me give you a drink of water." And then the dad looked at the son. He says, "You're trying to kill me." And the son started crying. Oh my gosh! It just tore me apart. I don't know. It was one of those days. And I was in and out of that room all day long. We did a lot of different things with that gentleman, and we finally start low, go slow, but titrate up the medicines. We gave him a lot of different medicine. We ended up giving him 150 milligrams of Thorazine, 50 milligrams at a time. That's a lot of Thorazine. 12 milligrams of Haldol. We started out with 2 milligrams. We went up to 3 milligrams. And went up to 4 milligrams. And then he had over 100 milligrams of morphine. And he was still rocking and rolling. I mean, he was still agitated. And then it finally caught up with him. He wanted to sit in the chair. He didn't want to be in bed. But before I went home, I was in and out of the room trying to make sure we got him comfortable and the family was okay. And when I left, he was sitting up in the chair and he was dozing, but you could still arouse him. So, you just meet the families where they are. I did cry in front of that son, which is it's good to cry, but I don't cry a whole lot, not as much as I should. I did cry in front of that son. I just couldn't help it. It was just so sad. But we did get him comfortable. The family was very, very happy he was comfortable. He did die a few days later. But they were very, we're glad he was here. We could never have handled this at home. He obviously had brain meds. He had that, I got to go, And, but we got him comfortable, and the family, everybody was able to come in and talk to him, and he was able to rouse up and talk back, and it ended up, he was very peaceful, and they were very happy. So that was a really, really tough case. If you ever want to read about hospice, Ira Byock is one of my favorite hospice writers. He's a national speaker, huge on the scene of hospice. And this is his saying, "No one should die alone, and no one should die in pain." So we all take that to heart and try to do the best we can to make that happen. But if you ever want to read any of his books, they're excellent. Alrighty. We don't have much time left. On the case studies,